thank you very much for having me for this session. I'll be presenting on about introduction of CAD4TB in Ethiopian National TB program, and practically give the lessons that we have from the field and show you the challenges we have and what we are looking forward. It's like in a way we can best use this technology in high TB burden country like Ethiopia. Next slide. Ethiopia is one of high TB and TB-HIV burden countries, recently removed from DRTB burden countries, and having an incidence of tuberculosis which is as high as 132 per 100,000 populations. And the treatment coverage over time is progressively improving and increasing, as you could see from the graph. It has been low for a longer time and currently is really increasing, and we are having very much improving case finding. The prevalence survey that was conducted in the country has clearly indicated that about half of the patients that we have in the country are asymptomatic. And then as you could see, having asymptomatic patients makes it very difficult to identify patients using the already existing case finding strategies, which mainly focuses on symptom-based TB screening. Meaning that if you use symptom-based TB screening, we'll be missing half of the patients which are already existing or incident TB patients in the country. With this one, with the estimate, we are currently missing about a fifth of TB patients which are estimated to be identified. Next slide. Being as a fact that using X-ray for TB screening as a long time known experience, there has been a major limitations in the country in terms of using just X-ray for screening TB patients. As you know, using highly sensitive TB screening tools is very important, but I think failing to use that was actually limits the capacity of addressing the needs of the patient, which actually have to be diagnosed by these technologies. So there is a limited use of just X-ray screening for TB in country, compounded by inadequate number of human resources available in country to be able to use technologies of digital X-rays. There is a major health system challenge because more professionals are located in urban areas, so you will leave the majority of rural population without access. And then, the infrastructure required for the previously known digital technologies is very much high, and it requires a lot of human resources and investment. Then besides this, the health system cost and challenge, it also impacts the capacity of the patients to get access to highly sensitive TB screening tools. So these are the major challenges we are having as a country in terms of reaching out for the patients, which we need to find and treat and give them adequate quality of care. Next slide. So based on the epidemiology of tuberculosis in the country, and also the available global guidance in terms of using highly sensitive diagnostic tools, we have worked with the country program, and the country program actually included the use of digital technologies in TB screening as part of the national strategic planning. And also, as you could see on the right side, the recently revised national guideline actually includes the use of digital X-rays in screening TB patients. So what remained in the country was having local evidence to see how they are practically working in the fields, and also having higher level advocacy for policymakers to make it very much usable and applicable in the context we are living in. As a country, following this revision of the guideline and strategic planning, the country introduced 4 vans, AI-mounted vans in the country. These are introduced to pastoralist communities. The community are very much mobile. We cannot really fix facility and make them come and use the service. So the country introduced mobile vans to the pastoralist communities of the 4 regions. As you could see, there are 2 in Somalia region and 1 in Oromia and 1 in Afar. So these 4 vans are dispatched to the communities to start the work of using the vans in terms of using AI for TB screening. Next. So this is just to give you how the pastoralist community look like. So, and the van which is actually available in one of the regions called Afar. So the community is actually mobile. You cannot bring them to a facility to reach and access the very much fixed health system. So now we use the vans in that areas. These vans are placed at in the pastoralist communities. The overall national orientation was provided. The health professionals were trained and they were aware how to use these vans and how to use the AI technology in the pastoralist communities. So the placement was very much supported by linking communities with the stations where the vans are moving for TB screening. And then they have placed a medical team linked with qualified health professionals and facilities. And then that started operation in the pastoralist communities. So this is how the vans which are mounted with AI technology are very much helpful for a community which is really mobile, which cannot really get them in a fixed place. Next slide. So with this implementation, actually, it only lasted 6 months. I have the data for the 6 months. We need to add more updated data. So there has been a screening which was conducted in the communities, and also additional testing was done to confirm the diagnosis using GeneXpert technology. So as you could see in one of the regions which we call Oromia, close to 4,000 people were reached out for TB screening with this technology. And then initially we screened like around 6,005 patients only using symptom. And also the same patient were accessed the AI digital X-ray CAD4TB. And then as you could see, the number of TB patients which are diagnosed from this is around 118 using back confirmation. And you could see how the CAD4TB has contributed in terms of reaching out patients in the pastoralist community. In Afar, it has also reached around 760 people, and then we screened around 445 clients who have TB symptoms, and then among them you could see around 62 patients were back positive among those who are screened by AI technology. And in Somalia also we have found around 92 patients using back positive, but around 300 accessed actually the AI technology for screening. So in the overall, close to 4,000 people were screened using the technology, and operationally we've seen how it was possible to operate with this technology in the pastoralist communities, and it has actually contributed to the increase in number of TB patients. More than 120 patients were diagnosed and linked to care because of the access people got while mounting the technology on mobile vans. Next. So based on experience from this, there has been very much increasing interest in the country to implement this technology. So there are local partners now which are coming in and trying to procure more technology to be used in their operation area. So one is registered as a local organization, which is now trying to get more technology to be used in urban areas. And also from our side, as Management Science for Health, implementing USAID project in the whole country, which is literally covering around 6 regions of the country. And the major regions like Amara, Oromia, Southern region are very much part of the project implementation. And then we have also presence in the zones where we can actually implement the advanced technologies. So with existing nationally existing vans, what we are doing is now two of the implementation areas are also in our operation sites. So we'll be maximally using these technologies to improve TB screening in the areas. And also in addition, we have also more interest in terms of using it for TB elimination studies, and also to increase access to screening in pastoralist communities, which are highly mobile. So this is the scope of areas we are working, and the increased interest which is within the country to use the advanced technology, which is AI mounted. Next slide. So one of the things that we are really doing is, from the map, as you could see below, there is a massive variation in terms of disease burden across different provinces in the country. And also this actually mainly affects some of pastoralist communities. And also we find that disease very much in a place where it is highly dense, and also hot spots where you have to really make interventions and really reach out for the patients to screen them at a time and also provide them treatment. So the areas you could see like in red are what we call our hotspots, which are mapping in the country. And these are the areas where you can use the CAD4TB and AI-mount technology in terms of easily identifying patients, as most of our patients are actually asymptomatic and we need to use the technology to assist the gap we are having in the country. Next slide. So as I have said earlier, we also needed more local experience, more local evidence, and also we need to really advocate to the higher level for the national TB program to allocate more resources to also expand the geographic areas and also use them with integrating it to the routinely existing health system. So we actually started a small scale piloting and trying to show that even whenever patients are coming to facilities, only screening them by symptoms actually leaves an opportunity for patients to be missed from diagnosis and treatment. So as you could see from the graph, the red ones, you know, the number of patients we found around 76. These are patients who came to facilities. They were asymptomatic, they only have high risk. And then if they were done by routine programming, they could have been definitely missed. So using screening by digital X-rays actually gives opportunity, not only reaching out for more patients, but also reduces the chance of missing patients within the facility and increase case finding. So this is an evidence really coming from we are bringing up for higher policymakers to expand the use of technology so that you can reach more patients and also improve case finding and provide quality of care. Next slide. So having said this, as I've mentioned earlier, in terms of the overall challenge that we are having, one, the infrastructure need is massive. If you are using the well-structured health system, which is fixed, one. The second point I mentioned was that there is limited number of radiologists who can actually read the X-ray result from the films. And then most of them are actually based in only urban areas, and there is very much limit for the patient, the Pascal's community and rural to be able to access these services. And also the cost it has on the patient and also the impact it has on case finding. So to address these things, there are strategic areas where we need to increase our engagement if you have to really influence the policy and encourage and also help the country to use more of the technology. So one of the things we can really do more is to work on building the national capacity. So this is, I think, one of the platforms. Also, national program has similar sessions where they have been receiving information about the global experience. This is being shared, and so we have to increase and maximize global experience sharing from different countries, how they operationalize, how they implement, and how they actually face challenges and also address them in practice. The second area where we need to really increase our engagement is we need to support local evidence generation. So as I've mentioned earlier, the 4 vans which are AI mounted with CAD4TB had actually provided more evidence that they showed the capacity of filling the gaps that the health system is having, the human resource capacity, the infrastructure capacity, and the cost capacity is really being addressed by using this technology. So it's technically and operationally, information and evidence is really coming more, and we need to increase building on this one. The third one is usually as a policy for policymakers, the most difficult thing that they are coming is they say, okay, it is cost effective. So having local evidence generation and testing patients with technology actually has shown or indicates how effective this is. And also it gives local governments to be able to really plan according to the effectiveness and its utility for the community. And then the third area where we need to really increase in terms of introducing technology to further to larger scale is, one, we need to have regular dialogue and engagement with policymakers. So they need to be aware, because as I've mentioned to you, we know the prevalence survey misses. The patients are missed by prevalence survey when they are asymptomatic. But in practice, we are not really, countries are not really going forward and using the targeted tools that can actually identify the patient. So increasing dialogue with national TB programs and also policymakers is one of the key areas of engagement. And the second key area to be engaged is engagement with professional associations. So it's good that we are aware. The clinical team is really using these ones, but higher impact could easily come by engaging professional associations. So one of the key ones in country where we're engaging are the Radiological Society of Ethiopia is one of the important actors because they decide, they work with policymakers about the technology, about its utility, and also they also engage their professionals that are working in the facilities, be it in urban or in the rural. So bringing them on board, working with them, and also empowering them to understand the technology actually increase the capacity of bringing in more technologies, also including the training and capacity building into continued professional development of the country, and also increases the utility so that we can actually bring on board more patients to get the service that they can provide. The second association we are engaging with is the Ethiopian Thoracic Society. So these are the clinical team. They are in the driving seat in terms of the overall pulmonary care of the country. So engaging them actually makes it very easy to work with the biggest and bigger university hospitals, which are very big ones, where they give their technical leadership for clinicians working in the fields, and also bring the knowledge of the advancement, its utility, and its practical application. So this level of engagement will actually make and rapidly change the capacity and the interest and the level of utility of these technologies in country. The last point from of area that we have to really engage is like, in some areas, we'll have countries have some operational challenges they may not really able to use because of limited resources. So what we do from our side, like a project, we really pull resources together, support facilities to be able to use it. Even we try to mobilize their technologies to be used in different parts of the country. So engaging in terms of pulling resources together, pulling our technical capacity together, catalyzing the efforts that the countries are making in terms of using technology is very much important. So finally, this technology is we found it very, very usable. One, because of the disease epidemiology requires it, that patients should not be missed. Two, it's very, very simple. It fills the gap of the deficient human resource capacity in country, so that it can actually assist them to easily read the radiologic findings and also interpret and make conclusive conclusion about the disease. And third, it actually facilitates and also assists the patient to easily access whenever it's mounted, like whenever it is mobile, and it can be reachable where it is highly required and highly needed. So we continue advocating for this, and will be also, as I've said, we are intending to do Eliminate TB study in the fields where we are intending to use this technology to screen rural communities, more than 200,000 people in the field, so that we can actually easily access them, easily screen, easily test, and also easily get the results, so that actually we can increase our case finding, we can actually fill our gaps, which is mainly about the infrastructure and human resource, and also increase case finding and quality of service we can provide. And this is very much welcome in the country, and NTP is very much interested, and we are working with NTP to continue to advocate for this one. Thank you very much.